All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. Once again, today we have a rock star with us. You all know her, so there is not a big introduction needed. We have Dr. Tess Lawrie from UK with us. She has been leading the effort for helping COVID suffering society at this time. The whole world is suffering with COVID at this time, and we need someone to get us out. So we are all doing our part, and Dr. Lawrie and her team is on the forefront. So Dr. Lawrie, welcome, and thank you very much for being with us.
Thanks, Dr. Bean.
So tell me this, we had this conference over this weekend, 2 days. How was the result? Are you happy with the conference? Would you like to share some of it?
Yes, we just had an overwhelming response. So many doctors from all around the world. I mean, at least, I gave up count, but there were at least 35 countries by the time we'd had a look. And obviously there were different time zones, so people were up at midnight and early in the morning, all hours of the weekend to listen. And most people who logged in stayed for the whole session. So we had a really amazing response, and also the emails we've had since, with so many doctors emailing us to say thank you so much. They learned so much. They are so keen to be using ivermectin and supporting our work. So it's very validating, and I feel like we really, all of us around the world who are working towards ivermectin, getting ivermectin approved, we have the mandate from the health professionals as well as from the people to really push as hard as we can to get ivermectin approved.
Got it. Thank you very much for this summary. So how about we do this from a structure point of view for today's talk? Let's have your take on the conference and some slides that you wanted to share. After that, we have some questions on Twitter. We have, of course, some questions here with the live audience as well. So does this about 45 minutes long program for today?
That's fine. I've selected a couple of my favorite slides, and so I'd love to share those.
Okay, let's see. Thank you very much for sharing.
So how do I share screen?
So,
there we go. So I see it's at the bottom. Yeah.
Yes. And for the cool beans, if you can hold on to your questions till after Dr. Lawrie has presented her slides, then I can pick up your questions. What happens is these questions scroll up and then they disappear, and it is difficult to find them.
Okay, at the moment it's got, let me just move that.
I see it.
Sorry. There we go. Can you see?
Yes.
Okay. Okay, so this was our 2-day conference on ivermectin for COVID. And I'm just wondering why I can't. There we go. So Andrew Bryant, he's a very keen golfer, as you can see. He sleeps, eats, and dreams of golf. So then we have a picture. He's actually my co-author on the systematic review that we've done, and he's a statistician, very experienced, wonderful guy. And his presentation was just so great, because what he's done is he's done what's called a trial sequential analysis, and what this is, I'll just show you. So this was our primary outcome, death, where we had 15 trials included, and we had a 62% reduction in deaths. And what a trial sequential analysis does is it plots the data from each trial as they are reported over a period of time. And its aim is to assess whether there's enough information to actually say we have enough data now, we can make a decision, or we don't have enough data. So it's a way of seeing whether your information size is enough. So in our analyses with the 15 trials, we have 2,438. These were hospitalized people with COVID. And there was a clear difference. But you all know that, the authorities are calling for more data, saying there's insufficient data and so on. So this is the trial sequential analysis that he did. He used 3 different methods. because there are three different methods described. And what this graph shows, you can see this line in the middle shows no difference. And this above there shows that ivermectin is favored as treatment, and below no, ivermectin is not favored. And each of these little blocks represent one trial. So, and this is over a period of time, number of patients. So we've got these with the initial studies that didn't really show any difference, and then these all show difference, and then we cross this line. Now this line is the required information size based on the analysis using this method, and it shows that 1,810 patients would be enough for the deaths analysis it would be enough information. We wouldn't need to do more trials. So you can see that there's 1, 2, 3, 4, 5 trials that have occurred after the required number of patients were achieved, that show that yes, the finding that ivermectin is favored because it's above the no difference, and we've got an excess of information. So this is very reassuring that we have enough patients in the analysis, we have enough data, and it's clear that ivermectin does prevent deaths from this analysis.
That is a beautiful analysis,
Yes.
and thank you to Andrew for doing this.
Yeah. So we're hoping that this will be also published along with our meta-analysis in the next 2 months, probably. Okay, so and then we had a wonderful presentation from Juan Chemi Quintero, who's been following, he's a data analyst who's been following the real world data on ivermectin since early last year. And most recently, he's looked at the European countries that have adopted ivermectin, including Slovakia and the Czech Republic. So he presented these data at the meeting, and I'll just show you a couple of slides that made an impression on me. This is the Czech Republic data, and they approved ivermectin in March for hospitalized patients. Actually, it's hospitalized because I'm just looking, because it says hospitalizations have been dropping sharply since the end of February, so perhaps it is more widespread. But so this is the plot of hospitalized COVID patients. You can see they have dropped off dramatically. And this seems to be the norm, sort of a 6-week period. Once ivermectin is started, a 6-week period, and then you get this rapid drop-off of cases. And this is deaths. So you can see they had, in early March, they were having 250 deaths per day, and now they're down to, what is that? It's 30 or so. So huge drop-off. And he explained that he did not think it was due to the vaccine because so far in the Czech Republic, they'd only vaccinated the over 70-year-olds. And when he looked at the data in terms of who was dying, and he excluded those of the over 70s, the shape of the graph was the same.
His work was actually beautiful, and I am waiting for his work from India as well. As there are some questions I'm seeing here. For example, there is a question. Sorry to put this question to you out of turn, but this may be something to percolate in the back of your mind. If ivermectin works, then why is it not working in India now? Does it mean it's not working on the new strains?
Yes, there's a few things we can talk about on that. What Juan has said is that Uttar Pradesh is still doing well relatively. To the province, or the provinces that are using ivermectin are still doing better than the provinces who aren't, states, I mean. That is the one thing. And the other thing is what I've heard from Dr. Mani Shapa in India is that they're needing to use higher doses of ivermectin. So they are using, instead of the 0.2 milligram per kilo, they're using 0.4 milligram per kilo. So it does seem there's an element of it being a more virulent strain, but also that in the states that are using ivermectin, it's a much better picture than those that aren't. So you have to remember India's a big place, and there are many states that are not using ivermectin. So there's that, and then there's also another angle on this, and that is that there is some view that there is a certain amount of disinformation as well about what is coming out in terms of in terms of the emphasis on, there seems to be this impression, well, ivermectin is not working then if India's doing badly and seeing all these cases. So there is a concern amongst people who are using ivermectin in India and elsewhere, that there are attempts to underplay the huge impact that ivermectin is having on cases in India.
And I can, my apologies, I can give 3 examples. So these are, of course, this is not a case study and not a representation of a large population, but 3 examples from my own team. I have a lot of team members from India. One of the team member is a doctor, practicing doctor in India. We teach medicine, so he's part of our team. And himself and his family became ill, and hospital did not want to give them ivermectin. They just did not know about ivermectin. When I asked for it, they asked the hospitals and doctors, they said no. Similarly, in the second case, we have an engineer. He and his family became ill with COVID as well. And I asked them, I stayed in touch, and I said, are you using ivermectin? And they said, what? So they didn't even know ivermectin is something. And in the third case, the person, he's our design lead, and he looked at, when I said that, hey, are you guys doing any prophylaxis? He said, no, there is no idea of prophylaxis here. And then when I said, has anyone talked with you about ivermectin? He wanted me to provide spellings for the thing. So there is a lot of awareness issue. There is a lot of, yes, it is said that it is used, but I don't think it is used that much.
It's not used that widely. In actual fact, someone contacted me this morning to say that there'd been a doctor on the BBC last night from India in a rural area, apparently a British doctor, and had been were absolutely dismayed at the deaths that they were seeing, but they were not using ivermectin. So the person who contacted me said to me, how can we get hold of this doctor and let them know, that they should be using ivermectin? So there seems to be, ivermectin is not widely used. If you think that India is such a populous nation that,
And apologies for inserting that question. I thought that is a hot topic and we should provide our comments. Back to you, Dr. Lawrie.
Okay, so I'm just seeing who we have next. And then it was so lovely to hear from Dr. Tina Piers. And she's been treating long COVID patients for a while now. And it's not her usual area, but she was interested in a mast cell activation. She manages patients with mast cell what is the condition? Mast cell activation syndrome. And she noticed that the long COVID patients had a similar symptom profile, and she's been managing them the same way as her mast cell activation syndrome patients. So it was really great to hear from her, and she's wanting to use ivermectin, and some of her patients are using ivermectin and finding it helpful. But as you know, in the UK, ivermectin is not approved for use in COVID, and there are all sorts of obstacles in the way of its approval. So this was really interesting to me. She was talking about how she manages her long COVID patients, and she puts them on a low histamine diet, and she uses antihistamines and mast cell stabilizers. And she says probiotics are essential, vitamin C, D, and B3, and then she uses these minerals, selenium, zinc, and magnesium. And as I say, she wants to add ivermectin, and she encourages her patients to use ivermectin if they can get hold of it. So I thought that would be really useful to people because there are just millions of people suffering from long COVID. And I don't think many of them are offered anything, actually, certainly not in the UK. There's very little on offer, and I don't think doctors are aware that antihistamines may help.
Got it.
And then I just realized I didn't put in Dr. Meddy's slide, but Dr. Meddy is an infectious diseases doctor in Scotland, and he uses ivermectin, and he's allowed to use ivermectin routinely in his immunocompromised patients with COVID to prevent them from getting a disseminated strongyloides or worm infection. So, he was just, he presented just to say, it's he's very stressed with the ethics around the official position of him not being able to use it for COVID, because doctors have always used treatments that they've always been able to use treatments that are beneficial, and suddenly now with COVID, we're being told what we can and can't use, and it's an unusual situation where the politicians and authorities are instructing doctors on what they're allowed to use to treat their patients, even if they, they're even, preventing them from using medicines that they know or think will be effective. So he was talking about the ethical issues and the moral issues, and also, just the fact that he's able to use it. It's sort of the strangeness of the situation where he's able to use it in his immunocompromised people with COVID, but he can't use it in his regular COVID patients.
Yeah, that was fascinating to hear him out as well. Very thoughtful discussion by him.
Mm. And then this was my favorite presentation, I have to say. It was the last presentation of the day yesterday, and it was Professor Macha Switter talking about the medical ethics and ivermectin. And he's a professor of medical ethics in Slovenia, where ivermectin is not approved. And he was talking about COVID and, who are the losers and who are the winners in this. And we have many people suffering with COVID, and also not just suffering from COVID, but all the lockdown measures and, the lost jobs, no cultural events, closed schools, limited social contacts, and much, much more. And the winners, being the pharmaceutical companies, the suppliers of protective equipment, the companies that are doing lots of online sales. And and then he talked about what obstacles there have been to ivermectin as a drug for COVID. I love this picture. Certainly, I hope, I think we'll just climb over this boulder. He was going, he went on to explain there's no funding for clinical trials. There are obstacles to publication of completed trials. So many people have had difficulty publishing their findings, including us with our systematic review, but there are many, many unpublished trials on the preprint websites that have been there since last year. There's promotion of trials designed to produce a negative result, and that's the JAMA study, which I think I've put in a slide in of that. There's the blocking of positive information about ivermectin. There's the releasing of false and negative information, and there's biased information from trusted sources like the regulatory agencies and WHO. So this was the JAMA study that was widely promoted and widely cherry-picked by the authorities as a an example of a great trial, and it shows no difference. But many, there are many flaws with this, interpretation of this trial. It was in mild patients, young patients, and there were problems with the randomization and concealment of the treatment. And so there are many issues which have been discussed by the scientists, and there've been letters written to JAMA by groups of doctors saying that the paper needs to be retracted, or at least certainly the emphasis on it being such a great example of a study on ivermectin needs to be reconsidered. But this is the paper that all the newspapers were fed or picked up on, and widely described ivermectin as having a negative effect, when, as I say, there are so many papers. I mean, we have 24 papers now in our meta-analysis on ivermectin, and this is just one of them. And then he talked about the censorship. I mean, there's so much. We could have had just 10 slides on censorship, but he talked about Dr. Corey's YouTube video being removed, and my original video on my appeal to the Prime Minister in the UK has been removed. And yes, so there was also Dr. Andrew Hill's review. There's been tweets that have been removed, and then in terms of publication, Dr. Corey's paper passed peer review and was later rejected without an adequate explanation just before publication. So lots of censorship going on around ivermectin. And he talked about the biased statements and negative promotion by the European Medicines Agency, the World Health Organization, NIH, and FDA. Often they refer to a study on, that was done by Cayley, the early study on mechanism of action. Yes, and about it not having, and needing high doses, and so it couldn't possibly work at normal doses, so and would be very toxic. So these are the sorts of ideas and disinformation that are being widely shared amongst these agencies. And then this is the last slide I'm going to show, and this was I thought very captures the shocking nature of Merck's statement, really, against ivermectin, given that it's been used so widely, and they did all the safety studies, and they came out saying that there's a concerning lack of safety data, and the way that Professor Zwitter expressed it was sacrificing one's own child, which just captures the enormous horror of what they have done. So
yeah, this Merck's statement and the way they have done it, they have one more drug as well, which has functionally very similar properties to ivermectin, but out of the 5 parts of ivermectin, 1 part. So to me, it seems like they just modified that molecule and just used the same molecule in a different name. So Dr. Lawrie, thank you very much for this. It was a fascinating discussion over this weekend. I think very valuable as well for humanity at this time. So thank you to you and your team, Bird Group, your administration, for doing this. Are you ready? So for a few questions. So we are at 9:25 Pacific time. We'll continue till 9:45. So another 20 minutes of questions, if that is okay.
Yes, that's fine.
Okay, perfect. Thank you. So Cool Beans, what we'll do is this. We're going to go over some of the Twitter questions, and I'm going to try to loop in some of the questions from the live as well. So let's start. I'm going to share my screen so we can see. So here, this was what we had tweeted out. And here are some questions. So first of all, we have Linda Richmond. She says, first, I want to thank her from my heart for her important selfless efforts. My question, how well does she think the ivermectin movement is going? What barriers remain? How can we civilians, non-medicals help? Thank you too, Dr. Bean.
Okay. I think the movement is going well. I think it's gaining momentum. The public is waking up. Doctors are waking up. And I think we have volunteers, people emailing us every day saying, can they go on our volunteer list, which is what we need. So in terms of how can civilians, non-medicals help, you can sign up to our volunteer list, or if you sign up to our newsletter or our volunteer list, I can share the email with Dr. Bean for doing that. And then there are resources for civilians. So there are letters you can take to GPs. There are letters you can share with your neighbors and your neighborhood, and or their flyers and so on. And the barriers that remain are massive. So we need your help.
Got it. Thank you very much. There are a few questions that are here. I'm going to do a quick rundown of those questions and probably quickly. So Liza is saying that, can we have this discussion? I think this is directed towards me. So yes, Liza, we can take up this one and talk about it. Colin Hamel says, Hemi from UK, where can we find the discussion online? I believe that Dr. Lawrie's group is working on editing the video, and then they would post it online, and we would all know where these are, and we will be able to go see them. Please keep in touch through
Group. It's bird-group.org.
bird-group.org. So I'm going to just write it down here for everyone to see. This is the most important place to keep in touch, bird-group.org. So here you can become participant. You can join the mailing list. So that way you know the information that is coming through. Plus you can see the other links here as well. So one more question that I saw here, which I think is interesting, and Dr. Mehdi kind of answered that a little yesterday. That question is, let me find it. The question was, how do we get ivermectin in UK?
There are a growing number of doctors who are willing to, who are prescribing it, but the best way is at this stage is probably to find a private doctor who is, because doctors are entitled to prescribe things that they believe will be effective for their patients. So you know, they've taken a Hippocratic oath. If they know about ivermectin, they may use it. So you need to find one of those doctors, and there are many doctors working within the NHS that are very fearful and afraid to use ivermectin, or they know nothing about it. So I would suggest you watch the videos of the conference, and there you might find doctors that would be willing to prescribe ivermectin.
Got it. Thank you very much. I'm gonna and Cool Beans, I have limited time for Dr. Lawrie has limited time. So what we'll do is we'll keep bouncing back and forth between the live and not. So Arun Mehta says, can ivermectin be used for ICU patients to remove remaining viral particles?
Well, I would say it certainly can be used in ICU patients. So what its mechanism of action is in those ICU patients may be a variety, and it probably includes inflammatory an inflammatory action as well, anti-inflammatory action, shall we say. So yes, it can be used. I'm not so sure whether it's removing the viral particles. Perhaps Dr. Bean has an answer for that.
So I can quickly just say this, that if there is a chance that during the ICU phase, the virus is still sitting somewhere, probing, poking, then ivermectin can be useful. So that means continuing ivermectin during that time is actually protective if there is a risk of virus sitting somewhere. If there is a risk of virus particles or broken up dead viruses sitting around in the cells, these would not be affected by ivermectin, other than, as Dr. Lawrie said, that inflammation would be controlled.
It was
Raju,
quite interesting. Sorry, Dr. Bean. I was just thinking about Professor Carvalho's presentation, because he was saying, the patients that had been treated early with ivermectin didn't get long COVID.
that is
And if you consider that the long COVID often, there's residual virus in tissues and that sort of thing. So I would think, we really have to push early treatment.
absolutely correct. So your stance here, Dr. Lawrie and Dr. Carvalho, is that give ivermectin early on, so that people actually don't end up in bad state or in long COVID state. That is such a profound statement. This is the early aggressive treatment that I have been asking for a long time. So yes, you're correct, Dr. Lawrie. Rajul Srivastava, question for India's double mutant strain. It's getting recommended to use 2 antivirals simultaneously. Can ivermectin and hydroxy can be given simultaneously? Will there be any benefit, or there are any contraindications by giving both of them together?
As far as I understand, there are no contraindications to giving them both together. And I've heard from doctors in Brazil who are saying that with the strain there, they are needing to use both together. And I really appreciate the feedback that we get from these doctors on the ground who are managing patients and noticing the response and giving this information to us.
Absolutely correct. And Rajul, I would just add this, that the individual contraindication to those drugs can separately be seen, but together there does not seem to be a contraindication. So Pezzo says Dr. Pierre Corey was quite explicit about Bill and Melinda Gates Foundation's its ties to WHO and vaccine and the possible vaccine lobby and lobby against ivermectin. What is Dr. Lawrie's opinion on that, and what can we do about it?
Yes, I agree that that there is, unfortunately, that foundation seems to be ideologically and financially very invested in vaccines. And so I do not think that they can really hold an objective position on ivermectin. I'm not sure what we can do about it, except to be aware of that position and question their role in anything to do with ivermectin.
Got it. Going to the YouTube site, GB says, is there any possibility of antibody-dependent disease enhancement in breakthrough cases we are seeing in India?
I'm not sure about that. I think we'll have to wait. And in fact, probably Juan Chemi Quintera is the best person to answer that question. Are you going to get him on your show, Dr. Bean?
I think so. So I was actually going to ask you for your permission to have some of the folks come on as well. So maybe I can ask you live. That's a
great idea. That's a great idea. There's so many good people.
Yes, so I would actually reach out to them, and I think they would be an asset. Their talks will be an asset. Pezzo Zoltan says, how can the cool beans and others help in her mission? What are the next necessary steps?
Well, we need everybody to speak to their doctors. You've got to make your doctors aware of ivermectin, direct them to our website. At the moment, you'll see we haven't got our evidence page up yet, but we will. There will be links to all the evidence. There'll be links to the conference videos and more. So the more you can educate your doctors and then your friends and family, and as I say, if you can sign up to the newsletter so that we can communicate with you, send you flyers perhaps that you can disseminate and that sort of thing, that would be really great.
Excellent. And just an anecdote, one of my class fellow doctors works in New York in an ICU. He manages ICU there. And a few days ago, we have a class fellows WhatsApp group, and I continue to put some ivermectin related things there. And a few days ago, somebody in our class fellows got COVID, and I said, please make sure that you are looking at ivermectin as a possibility to use as well. And they responded and they said, oh well, I did not know. And then this class fellow of mine who is in ICU, he said, in our hospital, so we're talking about New York, in our hospital, ivermectin is very commonly used and we use it all the time. And I was really thrilled to hear that. So I think Dr. Lawrie's comment that please continue to inform and educate the doctors around you, others around you, and it would keep getting traction. Esther Erasmus says, can we please urgently get a prophylaxis dosage update?
Well, if you listen to Professor Carvalho, he says it works, and he says it works at any dose, really. Sorry, my light's gone off. He says I don't mean any dose, but he says there's so many different regimen, and you don't need to worry too much about which one you're on. So that's why it's just the urgently. I'm thinking is not a necessary word when you're talking about prophylaxis. In India and in I think it was India, I heard from one of the doctors there, and they're using 0.2 milligrams per kilo every month, and they say that that's been fine. I don't know if now whether that's changed with the new outbreak, but Pierre Corey was saying he's been using it every fortnight, but now he's recommending it every week. So I certainly think it depends who you are as well, because if you're a healthcare worker, you probably want to be more, have it more frequently than if you are, if you're just a healthy individual. I don't really see the need for you to be taking it at all.
Got it. Thank you. Alan Stein, is there any recourse to the WHO regarding ivermectin?
Yes, there are many initiatives at the moment to address the authorities' position on ivermectin. So you can expect to see in the next few weeks, many different bodies trying to sort out what's going on with the WHO's position on ivermectin.
Got it. Thank you. Angelo, for Dr. Lawrie, have you considered pursuing legal action through human rights lawyers or organizations?
I don't think it's my position to pursue legal action. I think there are organizations who are equipped to do this and who will be doing this in as I say, the next few weeks.
Got it. I'm going to skip over the question for Fluvoxamine. I just want to stay, if you would like to talk about it, sure. I wanted to make sure that we are ivermectin focused. Question, if you wanted to take it, Energy, does she know about Fluvoxamine?
People have been asking me to look at fluvoxamine, so I know there isn't nearly the body of evidence on fluvoxamine as there is on ivermectin, but I am intending to look at it at some point.
Got it. Thank you. Ivermectin-covid.ch says, ivermectin's critics are focusing on the study quality risk of bias to dismiss their results and meta-analysis results as well. Could you take some time to, again, give your perspective on the study's risk of bias and how it affects your conclusions?
Yes. For our primary outcome, which was deaths, we focused on the randomization, sequence generation, and allocation concealment, because once you've properly randomized your patients in a randomized trial, and you're looking at an outcome of death, it doesn't matter whether it's blind or not, because death is a very objective outcome. If you're measuring something like time to or length of hospital stay, then you would want that to be blind, definitely. But for deaths, what you really want is to make sure your randomization procedure is tight, and if that's tight, then we were satisfied that that was low risk of bias for that outcome. So let me just look at the question again. So then the other thing is, most of the emphasis by the detractors of the ivermectin studies is they say is basically I think an ethnocentric criticism, in that they allude to the fact that they're not large, well-funded studies, suggesting that it's only large industry-sponsored studies, or because in actual fact the only large studies that we've done are industry-sponsored studies. And also there's this idea that those industry-sponsored or large charity or grant studies are better than other sorts of studies. Well, I beg to differ, really, because the studies that are conducted by doctors on the ground, who have no financial interest in the product, and have, they are so busy anyway. It's a labor of love, really, to do research as a clinician, and a moral duty. So the research is out of a moral duty, that it is done to share important knowledge. So I think the studies that have come out of Egypt and India and Bangladesh and Peru and Argentina and Brazil and Nigeria are actually really wonderful and valuable pieces of research, and they need to be acknowledged and recognized as that.
Got it. Thank you very much. One more question from here. John Bream. John Bream is a physician in the emergency, and I'm actually going to be on his show tomorrow. So John Bream says, what is her opinion on leronlimab? If she were just diagnosed, what medicine would she want? If she were intubated, what medication would she want? And I would say, God forbid. But interesting question. So of course, he's a ICU physician. So what do you think? Have you considered leronlimab and its actions?
I haven't considered leronlimab, no.
How about if you became ill with COVID, what would you take?
If I was very ill, I would take vitamin D, high doses. I would take vitamin C. I would take zinc. And I would definitely take ivermectin. And I would also consider hydroxychloroquine if I wasn't doing well. So I think I would start off with ivermectin and vitamin D, C, and zinc, and then consider some of the other fairly innocuous established medicines. Yeah.
Got it. Thank you very much for this. So we are almost at time. So a couple of more minutes. I'm going to stay now with the online YouTube side. So here, Lisa Marie says, how does hydroxy compare to ivermectin as a prophylaxis?
I can't really answer that. I haven't done a systematic review of hydroxychloroquine, and I haven't compared the two.
Got it. Ken says, can Dr. Lawrie provide any deficiencies she see in the WHO ivermectin analysis that led to their recommendations?
Well, there's a long list of them, but the main one is the fact that they have really used a microscope and super focused down on a select group of studies that will fit in with their network meta-analysis, which is the analysis that they're using to evaluate all the other treatments, especially the new treatments. So it's inappropriate for a medicine like ivermectin, where you need a more pragmatic approach because there are so many trials, on ivermectin, and some of them are with doxycycline, some of them compared to hydroxychloroquine. And using a pragmatic approach, you get a much richer analysis and understanding of how ivermectin works across, and whether you, no matter what you do, ivermectin works. No matter how you group the studies, it works, and it also it also completely, already, when you're just looking at randomized trials, you're already looking at a select group of studies when there's all these other data and other studies. So yeah, it's really unforgivable that they've just looked at those handful of studies. And then there's also what's also unforgivable is the way they've graded the studies, because they have downgraded twice for imprecision. So downgraded 2 levels. So they've downgraded for study design, which we also did, and they've downgraded twice for imprecision, for very precise estimate of as I say, they got 81% reduction in deaths, 64% to 91% as their confidence interval. So, which is very precise. So even if they, you could possibly say, well, maybe they could downgrade once, although I'm still not even sure whether that would be possible based on those data. So
unforgivable, as you said, is the right term there. One last question, Scarlett Monahan. Is there any evidence to suggest that ivermectin works against other coronaviruses like the common cold, standard flu, viral or organized pneumonia, or has any other inherent health benefits?
There are studies on mechanism of action that shows that it works against a number of different viruses. So I think we do need to look at it now that we know that it works for COVID. We need to be looking at it for all these other viruses and just giving it a try. There's nothing to lose. If I had bad flu, I would give it a try.
And I gave it a try when I had cold a few weeks ago. Cool Beans are actually aware of it. And it was not SARS-CoV-2. I was RT-PCR negative. My antibodies were negative. And I had that condition for about a week. I took ivermectin. I felt great. I stopped it in the middle and I became sick again. And I started it again and I felt great again. So placebo, maybe I think that it was actually a very decent solution. So Dr. Lawrie, thank you so much for your presence today. Thank you very much for your work, your whole team's work. I think that you are creating traction and there is a change that I'm seeing. So thank you very much for your work and thank you for being with us.
Thank you, Dr. Bean, for all you're doing. Thank you.
Thank you. All right. Bye-bye.
Bye.